Hi there, everyone. We are so happy to have you, whether you are joining us here today or will be watching later from our Cure GABA-A YouTube channel. We ask that you please mute your mics if you have not done so already, and include any questions that you might have in the chat box below. We'll have time to answer questions at the end of the presentation. My name is Monica Joanna Alacabe, and I'm the founder and CEO of Cure GABA-A, a nonprofit organization with the sole focus to develop potential therapies for GABA-A variants. By partnering with world-renowned researchers in GABA-A and the Organization of Patients for Clinical Trial. Today, we welcome Dr. Michael Rogawski, professor and physician at UC Davis Health, who recently joined us and presented at the 2023 inaugural Cure GABA-A Scientific Roundtable, which was in conjunction with the American Epilepsy Society. He has been elected a Fellow of the National Academy of Inventors, which is the highest professional distinction of academic inventors. His inventions in drug discovery and development, particularly in the field of neuropharmacology, have led to significant advancements in treating epilepsy and neuropsychiatric conditions. Notable achievements include the development of epilepsy drug Fycompa. Did I pronounce that correctly?
Yes.
And Zulresso, which was the first FDA-approved drug for postpartum depression. His work reflects a dedication to translational research and collaboration within the scientific community. I'm handing it off to you, Dr. Rogawski. Please help us understand GABA-A and its relationship to epilepsy.
Great. Well, thank you so much, Monica. It's a real pleasure to be here this morning. What I'm going to try to do is help lay people, that is, people who aren't scientists or researchers in medicine, to understand what GABA-A is, how it causes epilepsy, and how we might possibly be able to treat it. And before I get started, I just wanted to mention a few things about our goals at the end of the presentation. We want to think together about what could the most effective medicines be for the treatment of children with GABA-A variant epilepsies. And as we learn about the role of GABA-A receptors and how medications can affect the activity of GABA-A receptors, I think some ideas will come to mind. You and I, Monica, have talked about an observational study, and we raised the possibility of even evaluating whether caffeine might be of benefit to people who suffer with GABA-A variant epilepsies, and we'll talk about that this morning. And you asked me to highlight the fact that the GABA-A variant group has enlisted two organizations, Citizen and Matrix, to collect information on patients. So any participants in the group ought to be plugged into that, and you can onboard through the Matrix platform, which is linked directly on the Cure GABA-A website, and you can see the URL there to get started. In fact, on the next slide here, I show your very elegant website that makes it easy for a family to sign up for membership in GABA-A variant, the group, and also to begin to provide information. And this looks to me like it should be very, very easy for people to access. Okay, so one analogy that you'll often hear in the world of epilepsy is this analogy to a seesaw. And it's often said that the brain is like a seesaw because it's a balance between excitation and inhibition. And if we have excessive excitation, that can lead to an epileptic seizure. This can occur in several different ways. We could have an increase in the mechanisms in the brain that generate excitation, and the neurotransmitter glutamate is responsible for excitatory neurotransmission in the brain. But it also could be due to a deficiency of GABAergic inhibition, and we'll learn in just a few moments what we mean when we talk about GABAergic inhibition. But this is believed to be absolutely crucial to many types of epilepsies. So we have this theoretical balance, but I find that this analogy is somewhat lacking, because we know that the brain is a very complex organism. We also know there's no seesaw in the brain. So what is it that causes the brain to function like a seesaw? And in order to help understand that, I have created this cartoon, if you will, of a typical neural circuit in a part of the brain that might be involved in epilepsy. And you can see that there are two neurons. These are cells within the brain. One of them is referred to here as a principal neuron. You can see that it has a cell body that is triangle or pyramidal shape, and this one is a smaller neuron. These neurons are the excitatory neurons. They transmit, if you will, positive signals. When one of these neurons connects to another neuron, it turns it on. And that's why they're indicated with a plus sign here. These littler neurons, which are called interneurons, actually do the opposite. When they connect to another neuron, they inhibit the neuron or shut that neuron down. And these neurons are what we refer to as GABAergic interneurons. There's another kind that uses glycine that's not in brain regions relevant to epilepsy. The ones that are in the brain regions relevant to epilepsy use GABA as their neurotransmitter. And in just a second, we'll see what it means to use GABA as the neurotransmitter. But basically what happens here is that you have one excitatory neuron, one pyramidal-shaped neuron connecting to another pyramidal-shaped neuron, and that would cause excitation that could transition into an epileptic seizure. But we have these inhibitory interneurons that act as a neural brake that keep things under control and prevent the brain from transitioning into an epileptic seizure. Now, it turns out that there are many different kinds of interneurons, and they have different shapes. They have different chemicals in them, but they all use GABA as their neurotransmitter. And they exert their inhibitory influence close into where the cell body of the neuron is, this part of the neuron that has all of the molecular machinery. And the excitation actually comes in on the branches of the neuron, which are called dendrites. And the GABAergic interneurons, you see, are closer in, and they have a very powerful influence to regulate the excitation that comes into this neuron. Now, what is the neuron doing when it communicates with the next neuron? Well, it's causing a signal that's referred to as an action potential from being formed. And this neuron can only communicate with the next one when an action potential is generated. And these inhibitory interneurons prevent action potentials from occurring. If too many action potentials occur, it can lead to an epileptic seizure. So these neurons are very complicated in terms of their structure. You can see these are the pyramidal neurons here, and look at these inhibitory interneurons. They have all kinds of branches. It's like a forest. And this inhibitory interneuron connects to many different pyramidal cells. Only one of them is shown here in this diagram. When an inhibitory interneuron has an action potential, it causes inhibition in the pyramidal neuron. And you can see that here. Inhibition means hyperpolarization. And so that is essentially preventing this pyramidal cell from generating an action potential and signaling to the next pyramidal cell. So in a person who has epilepsy and where a part of the brain has a tendency to generate seizures, these inhibitory interneurons produce what's called an inhibitory surround. They keep the brain in the region outside of the epileptic focus in a state that doesn't allow the epileptic focus to escape from that local brain region. And as long as the epileptic focus or the region of hyperexcitability is contained, it doesn't cause the patient any trouble. But if it should escape and spread to other parts of the brain and encompass a large enough portion of the brain such that it can produce a behavioral event such as shaking of an arm or shaking of the entire body, that would be an epileptic seizure. And that's what we want to prevent from happening. And it's these inhibitory interneurons that do this in a person who has an epileptic susceptibility. So how do these inhibitory interneurons actually work? Well, they send their axons, which are their wires, to the principal neuron. And you saw in the previous images how complicated that could be. But what we're showing here is just a schematic illustration of the connection between the inhibitory interneuron and the pyramidal cell. It's also sometimes called a principal neuron, or sometimes a relay neuron, or glutamatergic neuron. There are many different names for it. But it's basically the excitatory neuron that is going to, if it gets out of control, lead to an epileptic seizure. So the axon terminals, or as I say, the wires from the inhibitory interneuron that connect with the principal neuron, contain the neurotransmitter GABA in little packets called synaptic vesicles. And these little spots in the center are intended to be the neurotransmitter GABA, the molecule of GABA. And when the nerve terminal is activated by an action potential, GABA is released into the synaptic cleft. It diffuses across the cleft, and the cleft is the region between the ending of the wire from the GABAergic interneuron and the dendrite or the cell body of the relay neuron or the pyramidal neuron. And when the GABA diffuses out, it binds to something called the GABA-A receptor. And of course, everyone who's listening to me knows the term GABA-A receptor because we are all part of the GABA-A variant group. And it's this GABA-A receptor that is the problem in GABA-A variant epilepsies. So we're going to talk about the GABA-A receptor in detail, but I wanted you to understand where it's located and how it operates. It's located in the principal excitatory neurons, the relay neurons or pyramidal neurons, and it's activated by GABA that is released from GABAergic inhibitory interneurons, the inhibitory neurons in the brain. For those of you who've studied neurophysiology, I'll just remind you that the GABA receptor is a chloride channel, which means that it allows the negatively charged chloride ions that are present at higher concentrations in the extracellular fluid. It allows chloride ions to go into the neuron. And when it does, it brings negative charge in, which causes hyperpolarization. And that's how the GABA-A receptors inhibit neurons. GABA-A receptors are located throughout the brain. They're particularly expressed at high levels in parts of the brain that are relevant to epilepsy. And as long as they're working okay, no epileptic seizure activity is generated in those brain regions. But when they don't function properly, because they have a genetic mutation or for some other reason, then epilepsy can occur in that brain region. Now, there are many different types of GABA-A receptors. And this is important because when we talk about GABA-A receptor variants, we have to specify which one of the components of the GABA-A receptor have the genetic alteration or the variation. So we have to understand how the GABA-A receptors are constructed, and that will help us understand the terminology when we talk about GABA-A receptor variants. So the GABA-A receptor is a protein molecule, and what that means is it's a chain of amino acids, a very long chain of amino acids in a sequence. But it turns out that there actually are 5 subunits of the protein. And so what that means is that you could separate these out. They're not actually covalently linked. They're not chemically linked to each other, each of these subunits. They're just simply arranged and held together by non-covalent interactions. And they come in different flavors, if you will. There are 5 of them, but typically 2 of the 5 are in a category called alpha. And then 2 more of them are in a category called beta. And then there is a third type, which in most cases is going to be gamma 2 usually. So you can see here in this diagram that there are multiple alpha subunits, alpha 1, 2, 3, 4, 5, and 6. And there are also multiple beta subunits, beta 1, 2, beta 2, and beta 3. And if any individual has a GABA-A receptor variant epilepsy, it'll be possible to specify which one of these proteins, subunits, is affected. And you should know that each one of these protein subunits is encoded by a separate gene that's in the genome. So you could have a variation, for example, in the gene that encodes the alpha 1 subunit or that encodes the gamma subunit, let's say. Here's the gamma subunit. Sorry, that was the delta. Okay. So we schematize the GABA-A receptor by these blobs, if you will, but each one of these blobs is a very, very complex protein molecule. Some of the protein is located within the cell membrane here. These are the lipid components of the lipid bilayer membrane. And you can see part of the GABA-A receptor is sitting in the membrane. And then you have extracellular and intracellular components of the GABA-A receptor. Now, remember that the purpose of the GABA-A receptor is to allow chloride to go from the outside of the neuron to the inside of the neuron. And when it does that, it causes the interior of the neuron to be more negative, and that is the hyperpolarizing influence on the neuron. Now, under normal conditions, the GABA-A receptor protein is actually closed for business, if you will. It doesn't allow chloride to go through. But when GABA binds to the receptor, and you can see that these are the binding sites for GABA here. When GABA binds, it causes the GABA-A receptor to open. And that allows chloride to flux through the channel, and it produces the inhibition. So just to remind you, we can go back here. And when GABA is released from the nerve terminal of the GABAergic inhibitory neuron, it diffuses across the synaptic cleft, and then it binds to the GABA-A receptor complex like I showed you, and chloride moves into the principal neuron, the relay neuron, the excitatory neuron. Okay, and in recent years, we've learned so much about the GABA-A receptors. We've been able to, for a number of years, know the sequence, the amino acid sequence, but in recent years, it's actually been possible to discern the three-dimensional structure. And this is done through a technique called X-ray crystallography, where crystals of the GABA-A receptor are bombarded with X-rays. But more recently, just in the last few years, and these are now major new breakthroughs that I'm talking about, it's been possible to use another technique called cryo-electron microscopy, where the protein is cooled down, and an electron microscopic technique is used to actually look at the protein molecule itself. So this is actually kind of miraculous. These are actually electron microscopic pictures of the GABA-A receptor themselves. Now, they put these kind of handles on the side here. You see these handles? These are actually antibodies, and they're added to the GABA-A receptor before they do the cryo-electron microscopy technique. And the reason they do that is because it allows them to orient the GABA-A receptors in different views, because you see that they're just kind of scattered in all different directions. And so what they'll do is they'll use these handles to orient it so that they can look at lots of them, and then they can get an average picture of what they look like. So using this technique, it's possible to identify specifically where on the molecule GABA binds. And you can see it's actually in a little pocket here between the alpha and the beta subunit. There's two binding sites for GABA on the GABA-A receptor in the two spots where the alpha and the beta subunits come together. The interface here is between the alpha and the gamma, and another interface between, or should I say, no, this is the interface between the beta and the gamma. This is the interface here between the alpha and the gamma. But at the interface between the beta and the alpha is where you have binding for GABA. When GABA binds to these sites, it opens up the chloride channel and allows chloride to flux through. Now, for many years, we've known that in certain forms of epilepsy, there can be brain damage that is seen. And so in the next part of the talk, I'd like to just touch a little bit on what we think is the basis for different kinds of epilepsies. And the big picture here is that epilepsy is due to many, many different causes. Some of them, as I say, is due to brain damage, and I'll talk about that first. But other types of epilepsy are not due to brain damage. they're due to genetic mutations. And when we look at the brain, we don't actually see anything abnormal in the brain. But we know that there are changes that have occurred in the brain as a result of the genetic mutation that lead that individual to have a susceptibility to have seizures, even though there's no damage seen. So let's first of all talk about a kind of epilepsy where we know that there is damage or there are changes in the brain. And this is a type of epilepsy called mesial temporal lobe epilepsy. It's a very common form of epilepsy. It's what's called a focal epilepsy because it's due to a change in a specific part of the brain, that is in the temporal lobes. And you can see in this image that was taken from 1889, so this has been known a long, long time, that in people with this kind of epilepsy, there's a shrinkage of the hippocampus and temporal lobe structures on one side. And this is believed to be the cause of the epilepsy. Now, there are many, many changes that occur in the brain in association with this process, this disease process. But one of them is believed to be a loss of inhibitory interneurons. And this is an example taken from an experimental model of mesial temporal lobe epilepsy in a rat. And in the normal rat, you can see these little black dots here. Those are called hilar interneurons. They're GABAergic interneurons, and there's lots of them. And they serve to control the activity of these excitatory neurons, which are in this black band here. Here's another black band, a different portion of the hippocampus that also contains excitatory neurons. But you can see that in an animal that has epilepsy that's like the mesial temporal lobe epilepsy in humans, there are very few of those black dots in the same region of the hippocampus. And so it's believed that the loss of these interneurons is at least partially contributing to the epilepsy. This control animal doesn't have seizures. This animal will have seizures every now and again, just like a person with epilepsy. And it's believed to be due to the fact that this animal is missing GABAergic interneurons and other factors as well. It's not just the loss of the GABAergic interneurons. So this is what's called a structural epilepsy, or an epilepsy that's due to a visible change in the brain. But GABA-A variant epilepsies are not like this. They're due to a genetic mutation that obviously you can't see if you looked at the brain, but you could detect it through a genetic analysis of the DNA. And it's due to the changes in the coding sequence, or basically in the spelling, the letters that make up the genes for the GABA-A receptor subunits. And you can see that there can be variations in all of these various subunits of the GABA-A receptor that we talked about, the alpha subunits, the beta subunits, the gamma-2 subunit that I talked about. And this designation here, such as A159S, the number here is the sequence in the protein that makes up this subunit of the GABA-A receptor. And the letters are the change in the amino acid at that position. So if you had alanine normally at position 159 in the beta 2 subunit, and then the mutation encoded for serine, that's what this designation indicates. And it can lead to a Dravet syndrome like epilepsy. Normally, Dravet syndrome is due to something completely different. It's due to a mutation in another ion channel called the sodium channel. But with these kinds of variants, you have a phenotype that is very similar to sodium channel derived Dravet syndrome. But you can see that there's many other kinds of epilepsies. And there are basically two broad categories of epilepsies that are due to variation in the GABA-A receptor genes. There are the so-called IGEs, or idiopathic generalized epilepsy. Sometimes these are called genetic generalized epilepsies, or GGEs. And then there are the DEEs, or developmental and epileptic encephalopathies. And these are very different types of epilepsies. Both of them can be caused by variation in the GABA-A receptors. Early on, when people began studying this, we had discovered that variations led to the idiopathic generalized epilepsies. But more recently, there's been a focus on the DEEs, and these are the ones that are more severe and challenging for families, the DEEs. The idiopathic generalized epilepsies are pure epilepsies. They are associated with seizures, and sometimes children who have them will grow out of them. They'll have them when they're in school age, and then by the time they get to be teenagers, they'll grow out of it. A condition called childhood absence epilepsy, CAE, is one of those. Others may have their epilepsy throughout their life, but they're very well controlled on medications. Juvenile myoclonic epilepsy here is a type of epilepsy that falls into this pattern. These people will continue to have epilepsy for their entire life most of the time, but it can be controlled by medications like valproic acid or Depakote. Unfortunately, the developmental and epileptic encephalopathies not only have problems of epileptic seizures, and sometimes they can be quite severe seizures, but they are also associated with other disabilities that patients have. And I'm sure that those of you who have children with this problem can talk about the kinds of challenges that your children are experiencing as a result of their GABA-A receptor variant epilepsy. Okay, so that's what I just told you. And I think what I'm going to do here is just highlight the fact that some of these GABA-A receptor variant epilepsies that are associated with DEEs, or developmental and epileptic encephalopathies, are associated with variants that cause the GABA-A receptor to not function as well as it normally would. And this is referred to as a loss of function variant. And the way you would characterize a loss of function variant is by studying the GABA-A receptor in a cell preparation, basically in a little dish in the laboratory. And we do that because we can much more precisely study the GABA-A receptors when we have them in cells that are in little plastic dishes that we take from an animal, rather than try to study them in the brain of the animal when the animal is kind of running around. It's hard to study when it's in the brain of the animal. And when we do this and we put the cells in a dish, and oftentimes we take cells that are, for example, kidney cells. And you say, well, why do we use kidney cells? And the reason is because they don't normally have the ion channels that we want to study, like the GABA-A receptor. So we take these cells and then we transfect them with DNA that encodes the GABA-A receptor. And we can do this using genetic engineering technology. And then we can also make a mutation ourselves that correspond with the mutation that a patient with one of these epilepsies would have. And we take the DNA from the normal GABA-A receptor gene and the DNA from the variant gene, and we can put those into cells. And you can see that was done here. And we look at the amount of chloride current, that is, how much chloride can flow through the GABA-A receptor when we add GABA, because remember, GABA opens the receptor and allows chloride to flow through. And we then compare what happens with the GABA-A receptors that have the mutation. And what you can see here is that if this is kind of the average amount that's flowing through the normal wild type, with these mutations, there's a smaller amount. Here, in this particular one, there's almost no current flowing through the GABA-A receptors that have this variation. This one, it's a little bit diminished from what was seen in the normal, called the wild type. So this is called the loss of function. The GABA-A receptor isn't functioning as well as it would under normal conditions, and this can lead to epilepsy. It's easy to understand why this would lead to epilepsy. There's not enough inhibition being generated by those inhibitory neurons to prevent the excitatory neurons from occasionally going into a hyperexcitable state and having a seizure occur. Now, more recently, it's been discovered that some GABA-A receptor variants actually do the opposite. They lead to a gain of function. And this is quite surprising, and we don't really understand how it leads to epilepsy. But let me show you what I mean by this. What's being done here is the GABA receptors are being expressed in cells in a dish, and GABA is being applied, and you can see that a chloride current is being generated. And as you increase the amount of GABA, you get a larger chloride current response. When you have GABA receptors that have a gain of function GABA-A receptor variant, you can see that you get a much larger current for the same concentration of GABA in the normal channel. This 10 micromolar here produces almost no current in the normal wild type channel. But in the variant, you see that you do get a large current. So this is what's called a gain of function. Now, ordinarily, we might assume that a gain of function should lead to increased inhibition and a reduction in seizure activity, but that's not what occurs. In people who have the gain of function mutations, they often develop epilepsy at an earlier age, and they may have more severe disabilities in addition to the epilepsy. So the gain of function is potentially more problematic for patients. And they also may have more severe and difficult to treat seizures. We don't understand why this is, but I'm sure that there's a great deal of interest among scientists to try to understand this, and hopefully in the years ahead, we'll have a better understanding. Another big question mark here is, how do you treat patients with GABA-A receptor variants that have a gain of function? We don't know how to do that yet. we don't know what the right treatments are. And Monica and I have been talking about ways that we could collect information that might give us some clues as to this. And if I have time, I'll touch on that in just a second. Okay. So one of the most important things for you to know is that in addition to the involvement of changes in the GABA-A receptor in some forms of epilepsy, the GABA-A receptor is actually a molecule that is responsible for mediating the effects of many drugs that we use in medicine, both in neurology and psychiatry and other specialties of medicine. This is another schematic illustration of the GABA-A receptor synapse, where this is the postsynaptic neuron, the pyramidal neuron or the relay neuron that I told you about. And you can see the GABA-A receptors are schematically shown in the membrane. And what I'm showing in this diagram is the fact that these various medicines can interact with the channel and cause a change in the function of the channel such that various effects on the brain can be produced. One of the most common drugs that affects this channel is called Zolpidem. It goes by the brand name of Ambien. You might have even tried it yourself to help you go to sleep. And this very, very commonly used sleeping medicine is a drug that we refer to as a non-benzodiazepine. I don't actually have non-benzodiazepines shown here, but it acts as a positive modulator of the GABA-A receptor. It increases the ability of GABA to open the channel. And this leads to a sleep-inducing effect, which we call a hypnotic effect. So that's one of the class of drugs that affects the GABA-A receptor. You may have also had benzodiazepines to treat anxiety or nervousness or panic disorder. Drugs like diazepam are often used for this. We know that diazepam goes by the commercial name Valium. So I'm sure all of you know that name. And it's a benzodiazepine that acts as a positive modulator. We also have epilepsy medicines like phenobarbital and ganaxolone. These are two FDA-approved seizure medicines that act on the GABA-A receptor as positive modulators. So the GABA-A receptor is one of the most important drug targets in the central nervous system, and lots is known about it, and many drugs affect the GABA-A receptor. When a drug like Zolpidem, the sleeping pill, Ambien, or diazepam, the anxiolytic, the anxiety, the drug that's used to treat anxiety, is added along with GABA, it causes an increase in the amount of chloride current. You can see that here. This is the same amount of GABA is being applied. It's opening the channel, causing chloride to enter the neuron. And then when diazepam is applied along with it, you can see that the amount of current that's going in is bigger than under baseline conditions where there's no diazepam present. And this is how diazepam causes an anti-anxiety effect, and Zolpidem is doing a similar thing, and that's how it helps you fall asleep at night when you take it before you go to bed. In my laboratory and many other laboratories, we can actually look at the activity of individual GABA-A receptors using a technique called patch clamp. And when we do this, we can study the effects of drugs like Zolpidem, diazepam, phenobarbital, and so forth. And we can see that these drugs increase the activity of the GABA-A receptors. Okay. So I mentioned already that there are these gain of function variants in the GABA-A receptor. And by all right, these gain of function variants should lead to a reduction in epilepsy, but they don't. They produce epilepsy that can, as I mentioned, be sometimes more severe than the kind that occurs with variants that cause loss of function of the GABA-A receptor. And Monica and I were talking about this, and we wondered whether if there was a gain of function, there might be an opportunity to use a medication to kind of tamp down the gain of function and bring it back closer to what is normally should be the function of that GABA-A receptor. Now, just like there are drugs that can increase the activity of GABA-A receptors, there are many, many drugs that are known that can inhibit the activity of the GABA-A receptor. And if you had a gain of function variant, it might be the case that these drugs that can damp down or inhibit the activity of the GABA-A receptors might be useful. There's a risk, of course, because if we inhibit the GABA-A receptors too much, that could lead to epileptic seizures. So we have to be very careful about this. But it's a concept that I think is worth us thinking about a little bit. Now, there are a number of drugs, as I say, that are known to inhibit GABA-A receptors, and these drugs have actually been used for various medical purposes over the years. The most common usage, and this was back in the early 1900s, in the 1910s or 20s, they were used to stimulate people who had taken drugs that were overly sedating. Back in those days, they used drugs that are referred to as barbiturates as sleeping medicines or for other purposes. And when people were overly sedated with the barbiturates, they were given drugs that are referred to as analeptics, analeptics, and these analeptic agents basically were used to wake up the patients. They're not used anymore for that purpose, and the reason is that if you overdo it, you can lead to an epileptic seizure. So they're not really used too much anymore. But they were very popular back in those days. And some of these analeptic agents, like pentyline tetrazole, picrotoxin, bicuculline, actually do dampen the GABA-A receptors. But other of the analeptic agents have other mechanisms of action. And some of them could potentially be safe. So caffeine actually is considered an analeptic agent. It can wake you up if you're feeling tired or if you maybe had a little bit too much of a barbiturate. Now, caffeine, as far as I know, is not a GABA-A receptor blocker like pentyline tetrazole, picrotoxin, or bicuculline. However, it does act as a brain stimulant, and it does so by activating or inhibiting, should I say, adenosine receptors in the brain. And as Monica and I were talking about this, we figured that many people with GABA-A receptor variant epilepsies might be drinking coffee and using caffeine. And we wondered, well, could caffeine be beneficial? Could it help any of the symptoms associated with the GABA-A receptor variant, including the seizures, but not only the seizures. Are there other impacts of the variant that could be benefited by caffeine? Well, we don't know that at the moment, but we certainly could ask that question. And we thought perhaps we could even do a survey of people with these variations and see whether coffee or some other form of caffeine, like an energy drink, for example, might be helpful. It's something we could certainly talk about. You can see here that camphor also had been used as a stimulant. There are other medicines. Some of these are currently available, like amphetamine and methylphenidate. These are used to treat attention deficit hyperactivity disorder. They have been used as analeptics to stimulate the brain. Could these drugs be useful in a gain of function variant epilepsy? We don't know, but it certainly could be studied. In addition to the foods and medications that I just mentioned, there are other drugs that are currently being studied or have been available and may not be available that could also be used as an analeptic in this situation. I just mentioned here this molecule called thujone, which is a component of absinthe, the drink. And it's well known to be excuse me, a GABA-A receptor blocker. There's a molecule called doxapram that is used to wake people up from anesthesia, stimulate respiration. It's a potassium channel blocker, which would also be a brain stimulant. Would it be useful? Ampakines are not available commercially. We can't get them at the drugstore, but they're under investigation. They've been studied for many things, including as a treatment for attention deficit hyperactivity disorder, for cognitive dysfunction and Alzheimer's disease, and they're also being studied as a respiratory stimulant. Could a company that's developing ampakines, would they be interested in applying these medications that they're studying for GABA-A receptor variant epilepsy? The serotonin agonist buspirone, which is an anti-anxiety agent, could it be useful? It's available at the drugstore, and we talked about caffeine. So with that, why don't I stop, and we can certainly discuss this. If any of you have any comments, I'd love to hear about them. And let's simply talk about this and decide, well, what can we do together that could advance our knowledge here and potentially benefit people who are suffering with GABA-A receptor variant disorders.
Firstly, Dr. Rogawski, I just wanted to thank you because that was such a wonderful presentation, and we have a lot of questions. So I'm going to hand it off to Martina, whose son's name is Dane.
Hello, it was a great presentation. Thank you so much for doing it. I did see my son a mutation on one of the slides in the very end. He has gain of function. He's 11-year-old right now. We still don't have his seizures managed. In fact, his seizures and dyskinesia exploded. And with each time he was trying to fall asleep, he was going either to seizure or to dyskinesia. And we had a difficult decision to make, use lamotrigine, which would take a long time, and he was on it, and it was really bad period for us. Or follow the advice of our immunologist and try doxycycline because she was suspecting microglia activation, and receptors, GABA-A receptors are on microglia apparently. So that doxycycline treatment helped with managing his those episodes. But we are not out of the woods, and we still have 1-3 seizures during the day. I don't know if there is anything when we were all this phenylbutyrate made me think about butyrate and about his results during the declines where he has strangely low urea results, but he has as well low ammonia, which is very unusual, and there is no rhyme and rhythm. But during that treatment with doxycycline, there was addition of butyrate as well added, and he still had horrendous smell of ammonia for a few days. So I don't know if there is connection and if that phenylbutyrate could be a drug that would work on both loss of function and gain of function through its modulatory effect.
Yes. Well, first of all, Martina, thank you for sharing your story. And I do have a couple of questions for you. What medications has your son been tried on, and what are your experiences? And secondly, what was the effect of lamotrigine? I know it didn't completely eliminate the seizures, but did it have a beneficial effect? Is he still on
It's hard
lamotrigine?
to say. I think there was about 8 medications that were tried over a decade, and they started with Keppra, clobazam, and added on the top of it lamotrigine within like first month.
Well, so, I'd be really curious to know whether clobazam had any effect one way or the other.
The worst effect was clonazepam. That was traumatic, and his
Well,
seizures
let me just jump in there for a second so that everybody on the Zoom understands. Clonazepam is a benzodiazepine. It's like Valium or Zolpidem that I talked about, and it causes a positive modulation of the GABA-A receptor. So if you have a gain of function, then you might expect that positive modulation wouldn't be helpful. In fact, it might be really problematic. So the fact that clonazepam sounds like the worst drug that he had gotten,
yes,
that
his seizures went.
certainly fits with what we understand the physiology to be.
His seizures went from every 1-2 hours to every 5-15 minutes. And because of the standard of care, and at that time, nobody really understand anything. Everybody were treating those genetics as loss of function. They made us stay on it for 3 weeks. It was a nightmare. And after they allowed us to take him off it and his seizure subsides, we actually used butyrate and cornstarch at that time, and somehow it helped. But as he aged and meets different stressors, infections, and environmental triggers, he has unfortunately other genetic mutations that contribute to a more complex picture. He has G6PD deficiency, and he has 2 channelopathies, calcium channelopathies, RYR1 and SATS-NA1S, that somehow might be contributing to it. For a short time, he was on bumetanide, Bumex, and it was actually a very stable period, but we didn't see any improvement in in his development, and it was mostly put for development. But other than that, it was really stable period. So I'm just wondering if there is any maybe indirect action of Bumex that somehow helps with GABA.
Well, bumetanide, as you know, is a diuretic agent. It acts on the kidney. And so there can be side effects related to its diuretic effect. But it has been hypothesized that it could benefit different kinds of epilepsies by basically increasing the gradient for chloride, because it is an inhibitor of one of the transporters for chloride, such that the gradient for chloride would be improved, and you would have a greater inhibitory effect of GABA. The problem is we don't know if bumetanide can really do that in the brain. There have been studies in neonatal epilepsy that didn't demonstrate any action of bumetanide despite the theory. So at the moment, it's really not known whether it can be useful in treating epilepsy, number one. But number two, I would think that for a gain of function variant, it would be just the opposite. It would be more of a problem, like what you said with clonazepam. So, but it's a scientific question, an experimental question. We just don't have enough information really to know.
With lamotrigine,
Lamotrigine acts mainly through sodium channels. It does not affect the GABA-A receptor as far as we know. And so it could be a good choice. There are many other sodium channel blockers, as you know, carbamazepine, oxcarbazepine, lacosamide is a sodium channel blocker. Many of the other drugs have sodium channel blocking activity, including cenobamate, which is a very effective drug and is a more recently available drug. So those are all ones that don't affect the GABA. Well, cenobamate actually does. I should take that back. Cenobamate has dual action. It affects both the sodium channel and GABA-A. So that might be a problem for gain of function. But drugs like carbamazepine, oxcarbazepine, phenytoin is an older drug that we don't use too much anymore. It's a sodium channel blocker. Lacosamide, it goes by the brand name Vimpat, could potentially be useful. It might be better than lamotrigine. It's a bit more potent on the sodium channel in certain ways. I can discuss that. But yeah.
The kids with gain of function, we as well notice a decline after anesthesia. He went sort of well with the first one, but there was a slight decline, and it's just now we are learning that there should be precautions for GABA-A receptor agonist medications. And in last MRI, when was done, they used different medications. But the decline.
What
decline,
medicine did they use? I mean, only ketamine is the only anesthetic that doesn't have GABA-A receptor.
There was ketamine, and there was something else with starting with D, but I would have to find it in my notes what exactly it was. Ketamine just was a little bit supportive.
Yeah.
And
well, that's good to, I would say that most anesthetics like midazolam is used, and that one is a GABA-A receptor positive modulator, so be careful there. Propofol is another one that's also a GABA-A receptor positive modulator, but midazolam would often be used, and it's probably good to stay away from that.
He had propofol, and the side effects that were after, it's just his stress threshold collapse. He's way more sensitive to any stress factors, way more than before that. And it's not just seizures, it's as well some cycling vomiting that's start happening after.
Yeah, well, propofol has several actions, but it is a GABA-A receptor positive modulator, and that's one of its anesthetic
Mm. Yeah,
mechanisms.
we have as well problem like what medications for pain to use, because there is so many different genetic, the GABA, the G6PD, and everything. So
well,
I'm
now for
hoping
pain, most of the pain medicines are not GABA-A receptor modulators, so I don't think you'd have a problem there. You have nonsteroidal anti-inflammatories, you have Tylenol, opioids. None of these are GABA-A receptor modulators. In fact, GABA-A receptor modulators generally aren't pain medicines.
Dr. Rogawski, I'm sorry, Martina.
Yeah, sorry.
We have a question that I received from many parents, and is it's important for us, in the case of kids with a gain of function, the first thing we need to do as parents is not to harm them. So I understand that what Martina is saying, it's very important, because we need to first come up with a list of things that can be harmful to avoid them. And then we need to treat these kids with treatments that would help them. But going to the first point, avoiding damaging medication, I would like to ask you if there is a difference between rescue medication when the kid is seizing, because we know that benzodiazepines are like the rescue medication that it's used in ER when you go into the ER with your kid in a status epilepticus or with several seizures. So we want to understand if this should be avoided also in that scenario, or if this is a recommendation that has to do with anti-epileptic treatment that would be damaging to, instead of preventing, causing the seizures. I'm not sure if I'm explaining my point, but I want to understand the
Augustina,
approach.
you're doing an excellent job, and maybe I can just repeat the distinction because it really is an important one. We normally use anti-seizure medications in a prophylactic mode. What that means is patients take them every day, whether they have seizures or not, and the intention is to prevent the occurrence of seizures. But we do also use certain medicines in the acute treatment of seizures as abortive medications or medicines to treat the seizures that are occurring at that particular moment. And there's basically two situations where this is done. One is called status epilepticus, where you have a persistent seizure that doesn't stop. And the other situation is called acute repetitive seizures, or ARS. It sometimes goes by the name cluster seizures or flurry seizures. It can be very variable, but oftentimes neurologists talk about it in the context of a person who's having two seizures in a 24-hour period, assuming they don't have that many normally. And we use certain medicines in this way to prevent either the recurrence of seizures in a cluster of seizures or just to stop the ongoing seizure during status epilepticus. Now, at the moment, the only medicines that are used in this capacity that are FDA approved are benzodiazepines, either diazepam or midazolam or lorazepam. They're typically the ones that are used. Alprazolam is under investigation, but they're all benzodiazepines, so they would all be positive allosteric modulators of the GABA-A receptor. Now, I don't know whether they would be harmful or beneficial for people with gain of function variants. I think this is something we need to accumulate information on. I think it's possible they could be helpful, because they generally have broad anti-seizure activity, and it's a little unclear what's going on in the situation where a person with a gain of function GABA-A receptor variant actually is in the throes of a seizure. So I think it's possible. I think it would be interesting actually to look in animal models and trigger a seizure in an animal, a mouse or a rat that had the same variant, and then see what would happen if you gave a benzodiazepine. So as far as I know, this is still an unanswered scientific question. So I think it's going to have to be sort of individualized family by family. You'll probably, if you do go to the emergency room, probably they will give one of these benzodiazepines, and you'll quickly learn whether there's a problem or whether it can be beneficial. And hopefully you'll report that back to us so we can all learn from that experience. But you'll also kind of make a mental note, and if you run into real problems like Martina did with the benzodiazepine, you'll know to let physicians know to avoid it in the future.
So as a summary, we need to have like a yellow light on anesthesia for any kind of procedure, and a look at the response after rescue medication with gain of function kids. That's correct.
Yeah. I think we need to really
Like,
collect
keep an eye on that.
information as a community. I mean, I think that's what's so wonderful about the organization that you all are involved in. Now, Laura looks like she had a question for me in the chat.
Oh,
And this is really very, very apropos to what we were talking about. And what Laura says here, an extra dose of valproic acid for a cluster of seizures has also helped, she says, my daughter in the past, especially with respiratory apnea seizures. So that's a really great point, that you could give an extra dose of valproate, which we don't believe is acting in the same way as GABA-A receptor positive modulators. Valproic acid, we don't fully understand the mechanism of action. It might be multiple actions. There may be some effect of valproate on actually the metabolism of GABA, but whether this is in any way related to increase in GABAergic function, the way that occurs with a benzodiazepine or barbiturate, I think is unlikely. I don't think valproate works that way. So, to your point, Augustina, you might make a note that telling the emergency personnel that valproate could be used instead of a benzodiazepine might make a lot of sense. Also, there are other intravenous and anti-seizure medicines. So valproate can be administered intravenously. The form there is called Depacon, Depacon, and there also are forms of levetiracetam, which levetiracetam also doesn't work on the GABA-A receptor, so it could very likely be safe in people with the GABA-A gain of function. And that one's available intravenously, and so is lacosamide. Lacosamide is available intravenously. So there are quite a number that could be used in an emergency situation. And this is going to be a tough sell to the emergency room because their knee-jerk reaction and their protocol is going to be immediately to give lorazepam, or in some cases diazepam, but mainly lorazepam is the one that would be used if in the emergency room if somebody comes in with frequent seizures or with status epilepticus. So having that quick conversation with an emergency room personnel and kind of explaining and saying, well, maybe Keppra would be better, or maybe Depacon would be better, or maybe Vimpat, which is lacosamide, would be better, is something that you might think about doing.
It's still important that we all keep in mind that when we go to the emergency room, we can give the doctors this input, like if the kid has a gain of function, explain that to them. It's a hard thing to to do, because we don't want to be, and we know with a rare disease, we are often loaded with the responsibility of deciding. Whereas if you have a child with, the flu, you will go to the doctor, they tell you what to do, and you just do it.
It's very difficult. It's very stressful. Doctors are trained to act quickly, and particularly for this kind of problem, we know that the most important thing is to terminate the seizure as absolutely rapidly as we possibly can. So it's going to be a very tough conversation. And then the doctors in the emergency room, of course, are exquisitely trained, but the kind of thing that we talked about this morning, they're not at all familiar with it. They've never heard of gain of function GABA-A variant. I guarantee you, they don't understand any of the physiology that we talked about. They don't really know how the medicines work. Not because they're ignorant. It's just not part of what they are trained for their everyday work. And so it's going to be a tough conversation.
Thank you. Julia, I see you're back.
Hi, thank you. Sorry about that. Hi, Dr. Rogawski. I thank you for doing this webinar for us. I jumped in a little more than halfway through, so I did miss a bulk of it, unfortunately, but I look forward to going back and watching it on the YouTube channel. I wanted to ask about, and I don't know if you covered this already, very quick backstory. My daughter has GABRB with a gain.
I'm sorry, Julia. You were just
breaking out a bit.
Oh, shoot. Can you hear me now?
Yes.
Yeah, I don't know what happened there. My daughter, Raina, she's 2, and she's very severely affected with GABRB3, gain of function. And I'm sure, like every family, it's been a roller coaster ride. We've been trying to find the best treatments, the best medications, the best solutions for her, and it's a wild ride. It's been extremely challenging and heartbreaking, and every emotion you can imagine. Trial and error with medications, and we actually just started learning about the gain of function aspect and medications to avoid, which is huge. As you can imagine, we didn't know about this even a few months ago. And so we are actively weaning Raina off phenobarbital, which she has been on for a very long time. She's also on Keppra, lacosamide, and sodium valproate. But the phenobarbital we had just learned about, I would say last fall, in that it's one to avoid with gain of function. And that was a huge revelation for us. So we've been weaning her off of that. And we see some positive changes in that she's, like, it has such a huge effect on her tone and her development. Like, she's very severely affected in every way. She has severe hypotonia, like limited head control, issues with secretion management. She had surgery to reduce her saliva production. Like, it's quite severe, what she goes through in a day, and she still has seizures every day. We're around 4 to 6 seizures a day. So trying to find the right mix of everything. She's on a strict ketogenic diet. She's fed via G-tube. The list goes on. But my question, of course, we want to know about other medications that might be helpful and others that we should be avoiding, but I'm going to go back and check this webinar to make sure I don't miss anything. But I wanted to ask about brainstorming. So like neurostorming, we call it brainstorms. She will have, and this has happened maybe a dozen times in the past 2 years, where she has intense periods of neuroirritability, neurodistress, and they last for days, like 4 or 5 days straight of just absolute distress. She's agitated, she's whining nonstop, she's barely sleeping, like an hour here, 5 minutes there, like barely sleeping in 5 days. And the first 1 or 2 times that it happened, we went into the hospital with her because we had no idea what was going on. We were afraid she was going into status epilepticus. And we did all, the gamut of testing. Everything came back normal. No one knew what was going on. And we are, trying to just figure out what to do, what to give her. And so that was the first 2 times. And then it's happened many times since, and we deal with it at home. with anything that we can think of, but nothing has really helped her like break through that cycle. And it's kind of just like a storm in her mind that runs its course. And then when it's done, and she's back to herself. But what's really interesting is that she's not seizing during this time. And she's been hooked up to EEGs like during this brainstorm. She's not seizing, but she's just in such distress. And we've tried a lot of medications, and the combination so far that has helped like that much is morphine and clonidine. And so we just kind of give that to her around the clock, but it's not really helping. It's just kind of taking the edge off. But she's in such distress. It's exhausting. She's barely sleeping. And I wonder if you know more about these episodes. Have you heard of this happening before? Are there medications that you've seen helpful in these cases?
Well, first of all, Julia, thank you for sharing your experience. And I'm really hopeful that by coming together as a group and sharing experiences like what you've been doing, we can all learn from each other, and ultimately we'll have better answers than what we can give today. I think the big picture of what I was communicating in my talk is that from a theoretical point of view, when you have gain of function, then potentially a medication that could tamp down or dampen the excessive activity of the GABA-A receptor could potentially be useful. And there are many, many different medications that are known to do this. The problem is that they all are generally not used because they're dangerous. They can cause seizures for the reasons that I described in my talk. They inhibit the function of the inhibitory system, and that can lead to seizures. But one wonders whether, very judicious use of these drugs, very careful use, could be beneficial. And the other thought I had is that there might be stimulant drugs that could be beneficial that don't act on the GABA system. So we talked about caffeine, right? That's a fairly safe drug. It works on adenosine receptors. It's not a GABA-A receptor blocker. But one wonders, could that be paradoxically beneficial during one of these storms, let's say, if the storm is due to excessive GABA-A function. Normally, caffeine would be a stimulant, but oftentimes in children, you get these paradoxical effects where a stimulant might be depressant and a depressant could be stimulant. And that might be particularly the case when you have a gain of function of the GABA-A receptor. So at the moment, I don't have any good answers, but I think that we have a little bit of a framework in how to think about it. And I think that ideally we'd want to do clinical trials, but it's hard to do that. They're very complicated and expensive to organize. So I'm just wondering whether collecting anecdotal information and saving that information in the resources that you'll find on the GABA-A variant group's website. And then we can kind of look at that all together and say, well, maybe clonazepam is something we should really stay away from in a gain of function. Just having one experience is not really enough, but if we have multiple people who have said, my doctor, before we knew what the diagnosis was, my doctor prescribed clonazepam or clobazam as another benzodiazepine, and it was problematic. We have that information, and it'll benefit, I think, all of the community. So, I mean, that's pretty much what I can say, is that we just need to be really careful. We don't want to harm anybody. Augustina prefaced her comment by saying that it's important. We don't want, the most important thing is we don't want to cause anybody any harm. Absolutely not. So we have to be really careful, but we have a framework for thinking about how we might explore some of these options.
Thank you, Dr. Rogawski. It's been very helpful to have you, and we of course know that you don't have all of the answers, because if you had, then we wouldn't be here today. We would be living our normal lives, but we know we are not. But now that we have each other, we are trying to set up a roadmap to find some answers. So I thank you all for being here today, especially you, doctor, who have invested your time and energy in thinking about strategies that we can start to use. And to all of the patients who could join us today, I thank you for taking the time to enroll on Matrix and Citizen. As Dr. Rogawski said at the beginning of the presentation, we need our community to get organized so we can run these questions across the community, and then take back all of the input so that it can be analyzed by all of the brilliant minds that have joined us in these efforts. So maybe Monica and I will get back to you on some idea of dosages, and we can share it if anyone's interested, and then we can circle back with any findings that we get after that. Okay.
Yes, well, thank you, Augustine, and also thank you, Martina and Julia, for sharing your experiences. And I'll look forward to continuing this conversation as we go forward and try to shed a little bit of light on this very challenging problem.
And stay in touch. Bye-bye.
Okay, thank you. Bye.